Good evening, ladies and gentlemen, esteemed delegates, distinguished panelists. Welcome to today's discussion on navigating health futures, equity, and inclusion in a dynamic world. For this session, we are fortunate to have speakers from diverse backgrounds, all striving for collective goal to achieve health equity. I would now like to invite Professor Yungtot Yuttavong, a distinguished scientist and a senior advisor to the President of Thailand National Science and Technology Development Agency. His extensive experience includes serving as Minister of Science and Technology and Deputy Prime Minister of Thailand. Next, I would like to invite Ms. Su Hussain, the Network General Manager at Unjani Clinics, which is a non-profit company who has been instrumental in driving access to quality primary healthcare services in South Africa through innovative strategies. I would now like to call upon Mr. Suji Santra, who is the founder and CEO of iCure TechSoft Private Limited, and he has been at the forefront of leveraging technology to provide healthcare solutions to underserved communities across India. I would like to invite Ms. Vaivavi Choksi, the General Manager for India and South Asia region at Gilead Sciences. Ms. Choksi brings invaluable expertise in building sustainable business models in the pharmaceutical sector and exploring cross-sector collaborations to amplify the impact of health equity and inclusion initiatives. And our final panelist is Dr. Nitya Mohan Khemka. She's the director at PART UK, and she's a seasoned leader in global health implementation dedicated to advancing inclusive healthcare solutions.
Thank you.
Thank you, everyone. And many congratulations again to the team from ORF and Gilead Sciences for the launch of this report, which offers a beacon of hope for inclusive healthcare services. As most of you know, the COVID-19 pandemic has served as a stark reminder of the existing gaps in healthcare coverage and inefficiencies in our health systems. It has underscored the urgent need for collaboration among various stakeholders, government entities, healthcare professionals, tech disruptors, innovators, and community leaders to address these challenges effectively and collectively. Therefore, our task today is not merely to acknowledge these challenges, but to engage in meaningful dialogue and action-oriented discourse that will pave the way for tangible solutions. It is crucial to recognize the evolving landscape of healthcare, particularly in the face of emerging developments such as telemedicine, advancements in digital interventions like vaccine technology and targeted therapies. With this, I would like to pose my first question about the smart utilization of technology and data to Professor Yukton Yuttavong, who has also been one of the lead technical experts in Health Equity and Inclusion Action Report. Professor Yuttavong, my question to you is how can we guarantee or ensure that advancements in healthcare technology are inclusive, addressing the diverse needs and perspective of all segments of the society? Over to you.
Thank you for that question. First of all, just a few words about my own background. I'm a scientist by training, a chemist, and then I taught for a long time at Mahidol University, which is the major medical university in Thailand. I then was the first president of the National Science and Technology Development Agency, a research agency, and then I became Minister of Science and Technology, and later Deputy Prime Minister, looking after public health, education, science, and social welfare. So I'm not a doctor by training, but I'm familiar with the medical scene public health scene. And as for your question, we cannot ensure that in any given country that all the various segments of the society will be treated, fairly and equally in terms of health welfare. But certainly, the system which is kind of called the Universal Healthcare System, UHC, which is in various forms in various countries, certainly that is a big help. The Thai UHC system started about almost 30 years ago as a brainchild of my former student who's he's dead now, Dr. Sangwon Nitya Rampong, who tried to have the system, adopted by the government of the time. And he was frustrated. The government said it's too expensive until one government, accepted that. And that government became very, very popular. So that proves the value of the UHC system. And I know this personally since when I was the Deputy Prime Minister, I had a occasion to try to convince the Prime Minister, General Prayut at that time, of the value of the universal healthcare system. And, it was so difficult for, normal politician to understand the importance of universal healthcare. So, but once you explain it and they got it, in this case, the Prime Minister got the message, they could really help a lot. So that is a very big boost for the Thai public health system. Another very important feature, and that concerns the policy part, not the implementation part, but the policy part is also important. The government at that time, the parliament passed the law for National Health Assembly. The National Health Assembly is both, kind of an assembly at the national level as well as, at the local level, so that people, from all walks of life can come together and form policy which the government has to follow, either the central government or the provincial government or local governments. They have to follow because that is by law. So I think that is a very important part. So I think that is my message for now. Thank you.
Thank you, Professor, for sharing and providing insight about Thai universal health coverage and the importance of policy. Now, I'd like to pose my question to Ms. Su Hussain. With your extensive experience leading a non-profit company that drives access to quality, affordable primary healthcare services in communities across South Africa, you have implemented innovative strategies. So in terms of that, what role does task shifting, such as delegating tasks from doctors to nurses and from nurses to community health workers, play in supporting and strengthening the health system?
Thank you for that, Sonam. So the Unjani Clinic model is built on the task shifting idea, where because of our medical doctor shortage in the country, professional nurses within their scope of practice can see patients, they can consult, they can also dispense medication. So what we've done is empowered nurses to become nurse entrepreneurs, then thereby easing the burden in our state facilities. What the nurse then does is open a primary healthcare clinic in a shipping container, and we then support the rollout of her infrastructure. There's business coaching and mentoring. She then creates employment within a community by employing receptionists, by employing community health workers. And what we're seeing more and more now with the introduction of community health workers, there's this hybrid healthcare outreach program where the community healthcare workers can go out, especially in our rural areas, and engage with patients who are needing to come into facility for care, or vice versa, being able to bring the nurse to the front door. We do believe within the model that in our country at the moment, education, healthcare education, is going to be the catalyst that shifts patient care. Because if patients have the right information, they're able to then, take responsibility for their healthcare needs. And what the Unjani Clinic model does is it allows healthcare to move from an acute service to a preventative model. And the nurses have a paid for model. So on average, our patients, we started in the missing middle, but now we also have social grant patients who are able to cover about between $10 and $15 for their consultation, and they get medication. And that just then allows us to have more patients on treatment. It gives the community healthcare clinics some kind of ease in terms of their load. And what we've now introduced with the primary healthcare nurses is to allow a virtual consult. So where you have something that's out of your scope of practice, you then dialing into a general practitioner. For another $5, the patient can see a doctor without incurring any additional travel, because most times patients would leave a facility and then not follow up for treatment. So that is what the model is built on. Thank you.
Thank you, Sue, for highlighting mentoring and coaching, and also the Anjani Clinic's innovative business model. That's very, and then for also highlighting that education as a catalyst in improving healthcare access. That's very informative. And for Mr. Sujay, I would like to ask, what are the challenges in accessing people in remote rural areas and urban areas with weak infrastructure?
Yeah, thank you for that, and thank you for the invitation to participate in this forum. Just to give a quick background about myself, I have worked in IBM and Oracle for 12 years, last in Oracle as a solution architect before landing into iCure, which we started in 2010. Initially, we were a pure technology company, and around 2014-15, we understood that just technology is not good enough to create the right kind of impact. We started experimenting on the healthcare delivery model, wherein we have a hub and spoke model, and now we have the frontline community health workers who are going out in the deeper pockets. Since the time when iCare has started, I have spent a lot of time spending in the villages, in the rural areas, trying to understand that how and why, being a techie, we understand that it's so obvious for us to adopt technology and many other things. Especially we have seen the adoption very easy in terms of telecom, finance and others. But when it comes to healthcare, there has been a lot of challenge. I remember the period wherein during the pandemic, for example, let's say for the state of Nagaland, wherein we were delivering the telehealth for the entire state of Nagaland, every 50 kilometers, the language changes. There are dialects which are so complex. And even for a country like India, for every 100 kilometers, the food pattern and other things changes, which means that the disease profile that may be stronger in one region, in one state, may not be the same in the other regions. So obviously there is one, in terms of the infrastructure related challenges, of course, we are seeing that is improving. There are cultural, social challenges which are there. For example, we have seen that even if the doctor is writing iron and folic acid, that the mothers won't take that, thinking that the baby would be dark in color. So it's not only about the unavailability of the doctors, it's also about whether the population of the community is willing to take those services or not. During the pandemic period and the post-pandemic period, we have been able to drive the vaccination. We have seen so much of vaccination hesitancy just because there were certain rumors and certain myths that we have seen. Even in the urban settings also, we have been working in many areas which is extremely populated, densely populated, and these were the hotspots during the COVID outbreak. So really working on those challenges on the ground in terms of the adoption, in terms of the cultural ethnicity, in terms of the socio-dynamic conditions that we have seen, and understood that if we really want to create a more healthcare resilient society, we have to think of much more stronger models.
Thank you, Sujay, for highlighting the challenges. Again, it brings back to education to create demand for health services. You did highlight that one of the challenges is demand from the communities. And then building on what Sue has mentioned, educating the people. So in terms of advocacy and all, that's what I feel. Now coming to Ms. Waibaby Choksi, with your experience in building sustainable and profitable business models in the pharmaceutical sector, what potential do you see in cross-sectoral collaborations to amplify the impact of health equity and inclusion initiatives, particularly in our region, in Southeast Asia? Yeah. Thank you.
Thank you. Thank you, Sonam, for the question. And today I'm sitting with colleagues which are across sectors, which is a brilliant example of how cross-sectoral teams and people can come together and deliver healthcare solutions. Uh, if you really ask me what does cross-sectorial collaboration means, I would say personally it's more of a collaboration than a partnership. It's partnership wherein we are trying to work together to ensure that we are able to have healthcare delivered to the people who do not have access to healthcare. So that is something which I feel it would be moving towards to. At Gilead, we work with various stakeholders, be it NGOs, be it community workers, be it academics. We try to work with as diverse stakeholders as possible. And the whole aim and objective is to increase the diagnosis, increase awareness, increase care and treatment, and not the less, but for disease areas like HIV, hepatitis, infectious diseases, as well as I would say Kala Azar, which we also as known as visceral leishmaniasis. So that is something which we work at Gilead. I would like to quote an example here where Gilead has been um providing support, and it's a commitment, I would say, more than support, where from 2013 onwards, we are able to provide medication in terms of donation, or also in terms of, I would say, a completely non-profit cost where we don't make any profits out of that donation or selling that product, and where we provide it to countries which are impacted by visceral leishmaniasis. And to be really just to make a highlight a point where after the program was launched, there's a decline of 91%. So from 2013 to 2023, there's a decline of 91%, which is tremendously, I would say, a great achievement. And the reason I say that, because this disease doesn't happen in urban areas. It really, you see this type of disease happening into very rural areas and very difficult to reach areas, where even reaching out and sharing the information, sharing the overarchingly understanding of the disease and what needs to be done to overcome is difficult. So that is something which we at Gilead are poised, and we are really committed to work towards to. Just wanted to even highlight one more aspect, and it's a brilliant milestone which Bangladesh as a country has achieved of elimination of this disease called Kala Azar. So that is something phenomenal, a country which is able to achieve this status last year, 2023. And India is very close to achieve the same status of elimination, hopefully very soon. So that is something which is commendable, where governments and WHO works together and ensures that diseases which impact the community and the people who are less fortunate, and how they are able to tackle such difficult causes. Also, I would say that Gilead as an organization is poised, and like last year, this 2022, where we further extended the support to this program by providing funding for the next 3 years. So that is something where we would want to say that we are there. We are more than poised, and we are very dedicated and committed to, I would say, causes like elimination programs. So that's a little bit about what I feel about working together, because I feel that a single stakeholder cannot achieve. It's always a collaboration which would help us to achieve such milestones.
Exactly. Thank you, Ms. Waivavi. our last panelist, Dr. Kemka. Your extensive experience in leading global health initiatives at PATH, how do you believe that we can ensure that healthcare advancements are inclusive and catering to the diverse needs of all sections of the society?
Thank you, Sonam, and I will add my thanks to the panel here. Thanks to ORF for inviting us to this very prestigious dialogue, and to all of you who are joining us this evening for dinner. I promise we won't keep you too long between dessert, for your dessert. But to answer your question, Sonam, I think the world cannot achieve universal health coverage if health systems and health innovations are not inclusive. And I think inclusivity is an ethical imperative, but the benefits of inclusion can be felt across society. So all of society benefits from inclusion. We're in India, so I wanted to talk a little bit about India today and give you some examples of the current policy framework around inclusivity. And I think India has made promising strides in healthcare coverage, to expand healthcare coverage. We have something called the UHC Service Coverage Index, and in India that's about 63 out of 100. This is double than what it was even 2 decades ago, so the country has made rapid progress. And the cornerstone of this whole idea of inclusivity in India is what we call the National Health Mission. The National Health Mission, the focus is to expand affordability, accessibility, and quality of healthcare, particularly in rural areas in 18 Indian states, which have unmet health needs and weaker health infrastructure. The NHM is a cornerstone of inclusivity in India because it embraces the whole idea of decentralization, devolving funds, functions, and functionaries in healthcare, particularly with public health, to the local level, which means the priorities of the most vulnerable and the last mile are put front and center in the process. The NHM also, the National Health Mission also focuses on the social determinants of health. We know that public health is much more than just the physical quality, but it's also looking at nutrition, water supply, sanitation, and the whole gamut of services. We also know that a whole range of barriers exist to accessing healthcare, and not least amongst that is the high cost of healthcare. And to remedy this, at the national level, India's Pradhan Mantri Jan Arogya Yojana is tackling this issue. In many senses, this initiative is the world's largest government-sponsored health insurance scheme. It has served over 100 million families, and it enables access, the most vulnerable to access a stunning suite of nearly 1,350 medical procedures, diagnostics, and other treatments. We also have something called the Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana, which basically provides generic medicines at a fraction of the cost to branded drugs. And this has cut the price of some medicines by 50%, in some cases by 80 and 90%. And the scheme offers 1,800 drugs, including essential drugs like insulin. So obviously, this has really expanded inclusivity in India. There's not only the cost of accessing healthcare, but there's also how do you get to healthcare. And there is a Janani Suraksha Yojana, which actually provides direct cash transfers to poor pregnant women so that they're able to get to hospitals in time. And since the scheme was rolled out from 2002 to now, the last figure I saw was 2016, institutional deliveries have increased from 18% to 52%. So clearly this is working to expand inclusivity. Now, Sujay has talked a lot about technology. India, as you know, is doing a lot with respect to technology. We have something called the e-Sanjeevani initiative, which is the telemedicine, which is in many senses the world's largest national telemedicine service. It served about 200 million, Sujay, and you can correct me if I'm wrong, 200 million patients, and over 50,000 patients a day. And then finally, the point I want to make is inclusivity is a fundamental right. It cannot be overstated. But by merely developing innovations is not enough. Innovations will only be successful if we can actually get to the last mile, if we can actually move the needle on public health outcomes, if the target groups have been reached. And in 2024, we've seen there are so many health innovations, but not everybody is reaping their benefits. And I want to actually quote the example from the global north. Between Europe's 30-fold increase in measles between 2022 and 2023 is a stark example of the implementation barriers we face even in rich countries. Most European countries have an MMR vaccine. It's a simple 2-dose vaccine, 97% effectiveness against measles, and yet after COVID, we're finding that there's a lot of vaccine hesitancy, a problem in uptake, and a lot of problem in misinformation around vaccine uptake, not just for the measles vaccine, but for various other vaccines. So we really need comprehensive multi-pronged strategies to generate demand for innovations, and for these strategies to be impactful and inclusive, they need to be specifically designed to target marginalized groups in the context in which they grow, they live, and they work. Thank you so much.
Thank you. Thank you to all our esteemed panelists. Now we'll open the floor to questions from the audience. We have time for approximately 4 questions only. Please indicate the panelists you are addressing, and please keep your question concise. Thank you. For the floor. Questions from the floor.
Thank you. I'd like to address this to the entire panel. I'm Subhavika, I'm from South Africa. And I'd like to ask, in terms of the risk communication and community engagement that you were referring to during the, when you were addressing your vaccine hesitancy during COVID, because we saw a great bit of this in South Africa. And we found that health education was just not enough. There was behavioral change strategies that we really required. So from your experience, did you all, what strategies did you all use other than just health promotion and health education to address these? And going forward with the misinformation and disinformation that now we're seeing that's erupted with vaccine hesitancy in general, how can we address this going forward? Thank you.
So from our experience, what we have seen is that it's true that the information or the community mobilization is definitely one part of it, but at the same time, what we have also seen that really works is the peer-to-peer learning, meaning that that we have also demonstrated in case of when we want to, like when we are providing integrated maternal health care delivery in some of the very remote areas of West Bengal, Jharkhand, and many other states in the northeastern part. What we see is that the first trimester pregnant mothers are simply not reporting to the government systems. And what we see is that there are a lot of social and cultural taboos like Kala Jadoo or the black magic and things like that that may endanger their babies. So in this case, when we are able to work with the village head, we are working with the communities and others, and as well as when we are able to bring these first trimester pregnant mothers to say that, okay, on 9th of every month you have a Tikakaran day, which is the vaccination drive day. Thank you for coming here. But we would like to know that, are you able to also bring your neighbor who might be also pregnant? So in this case, what happens is that when this would-be mother is coming and reporting at the healthcare facility, and they are able to understand the benefits, and when they're going back and sharing those stories to their neighbors, definitely that's a huge aspect. So it's not only about the top-down community mobilization model that can work, it's also about the ground mobility, it's also about believing the others, believing within the ecosystems. That has definitely worked. And here, we have also seen is that we have to understand that who is the decision maker within the family. For example, let's say for the pregnant mothers, the pregnant mother is not the decision maker. In most cases, it's either the father-in-law, mother-in-law, even the husband. So in this case, when we have to influence, the influence has to be done in totality, meaning that the families, the communities, the village heads and others has to work in tandem, has to understand that this fundamental thing which you are trying to do has to be accepted at all. And that is how we have been able to drive the things from a 360-degree approach. And that is how we have been able to bring 100% institutional healthcare delivery in some of the most remote districts in Jharkhand. Thank you.
Are there any more questions from the floor?
Hi, my name is Simi. I'm from the U.S. Department of State. I have 2 questions. Could you please talk about how we could encourage governments to increase healthcare spending? And you also recommend using AI and big data to address these challenges. Can you talk about how you can ensure that these mechanisms are inclusive and don't perpetuate further discrimination? Thank you.
Professor, would you like to take this?
Yeah, it's very difficult to ensure that, and we are very familiar with the term digital divide, where people who are less fortunate and less able to be familiar with new technology get left behind. and it's going to be worse in some cases, with the digital, when digital becomes AI. So I think your question is really very important. But we also know that when it is really important, people will find a way, although they don't have enough background, but they find a way to work, with the new tool. So, I was really amazed a few years ago when I was looking after the water information, information on how to manage water. And we went to a village where, just the normal people who are really very far from technology, but they realized that remote sensing technology is important. And they could handle remote sensing, just normal, village people who could handle remote sensing for the benefit of water management in their society. So I think that there is hope, but of course it's not every case, not every case that becomes successful, but when there is a will, then there is a way. Thank you.
Thank you, Professor. Any more questions from the
I can jump in briefly about the healthcare spending. That was your second question. Look, that's the elephant in the room. I think all governments need to spend more on health. And the problem is with reduced fiscal space in many countries, with increased threats like climate, like war, and with all the other pressures, the structural adjustment and reordering economies and the macroeconomic pressures, it is very difficult. But empirically, we know that spending on health and education is very key because it provides the future workforce, the country with the future workforce, and a solid grounding. But the reality is it is extremely difficult, and now we're competing with so many other pressures that governments have to contend with. It is the elephant in the room. I think what we can do is put out more sort of empirical work in the space that demonstrates very clearly the link between health, nutrition, the social determinants around public health, and education and social sector spending, and how that links directly to GDP and economic growth. Sorry, I don't have a straight answer.
Yeah, there's one there.
So this is not really a question, but something interesting, a comment to build on the question which was asked last. So think of it how technology is powering healthcare access, and a classical case would be use of penetration of smartphones, wherein there's a very interesting case study in India, wherein a large institute, a tertiary care eye care institute, has kind of used connective system to link about 29 districts, and thereafter screening the patients who had risk of age related macular degeneration, where images would be sent from different center to a central place, and based on scanning of these particular images, they could actually assess the risk, and based on that actually divert the patient to the specialist, by virtue of which kind of technology enabled access to diagnosis. And based on this particular diagnosis, people who would have otherwise kind of had delayed treatment for a progressive disease, they could actually get treatment earlier, and this has been quite transformational. I'm sure we would actually see more such cases moving ahead.
Since there are no further questions from the audience, are there any further questions? We can take in one last question before we close this session. Since there's no further question, can any of our panelists, do you want to speak? If you have any
Yeah,
additional-
on the AI piece, for example, at iCure, we have been implementing a lot of AI-related systems, and I'm also part of the National Core Committee for CII for Artificial Intelligence. We have been using AI in many ways since 2017-18, and what we understand is that in a low resource settings, if we are able to optimize a lot of things on the ground, and AI technically what we understand and what we want to do on the ground is that how do we ensure that the data which is coming in is accurate? That is the most fundamental thing. because without the quality data, no matter what you want to build on AI or data science, it is not going to work. So here, our community health workers, either in a private setting or in a PPP collaboration, we are able to understand that whatever data that is coming in is in automatic, meaning that the data is completely pushed automatically into the devices with minimal or zero human intervention. So that is how we have been able to focus in the quality of the data. And now we are able to apply AI even for many things like LLM AI, which is like improving the conversational between a patient and the health worker and a doctor. We are trying to use AI to improve the supply chain modules on the ground, meaning that, let's say if there is a distribution load, how we can understand the distribution based on the demographic and other geographies, and how you will be able to optimize using AI. So there are many aspects wherein, especially in the low resource settings, and we can even influence the government that in many cases the government does not have enough data to understand that where is the problem kahan pe hai. And that is where, once we are able to optimize the AI and optimize the resources wherein the resource settings are low, we can definitely do much greater things. Thank you.
Thank you. With this, I would like to sum up some. Okay.
I'd just like to add that not only AI that is, could be really used very favorably by the common people, but I think it's really not even technology. It's really chatting of people, which is enabled by the technology right now. That really can give you the clues to what's happening in the ground, some new diseases coming, some new pandemic, or some other, important health threat is coming. I think chat group is really very important. And I would like to mention that in Thailand and many other ASEAN countries, the Southeast Asian countries, we use this is a Chinese model of 137 in order to follow malaria. When there is malaria in the village, then the 137 strategy is used. One is to report the case very quickly in one day. And 3 is really to investigate, various factors in 3 days. And 7 days, in 7 days, you have to really have a strategy, for dealing with the cases of malaria in that village. And it is the chat group that is very important in order to kind of identify where the trouble spots are. So I think perhaps not even high tech, just the communication among people, that really is quite important. Thank you.
Yes, I agree. Communication is the key, and also the importance of monitoring the access to healthcare services. Moreover, I feel the transformative potential of technology cannot be understated in narrowing the healthcare disparities that we just discussed. And whether through telemedicine solutions, reaching remote areas, or AI-driven diagnostic, enhancing the speed and accuracies, technology has the power to democratize healthcare access and reshape the future of medicines. But of course, we should not ignore the community-led initiatives that has been discussed by our esteemed panelists in driving meaningful change. With this, I would like to thank my panelists and the audience. Thank you.